Next, we have Dr. Vetrivel from Ranipet presenting Connecting to the Dots, OSA and Cardiometabolic Syndrome.
Good evening, one and all. Respected chairpersons, my dear colleagues, at the outset, it is my duty to profusely thank the hero of the day, Dr. Shankar Subramaniam, and dear friend, who is the mastermind behind this meticulously arranged program on OSA. We'll be discussing about OSA and cardiometabolic syndrome connection. Introduction, we will have the prevalence and mechanism and clinical burden, conditions surrounding OSA and major cardiometabolic complications, mechanism and pathophysiology, OSA and metabolic syndrome, heart failure, arrhythmias, treatment, emerging therapies, clinical implications. In this narration, we have much of overlapping because of the conditions that are surrounding OSA are similar pathophysiological. So the OSA and the cardiometabolic syndrome ask at a bidirectional relationship like insulin resistance and diabetes, obesity, systemic cascade involving inflammation, hypertension, heart diseases, and dyslipidemia are bidirectional, setting a vicious circle. See, the OSA is having connection with all sort of cardiometabolic disorders. Obesity is the major risk factor, and BP elevation and impaired glucose metabolism also one. This connection is underdiagnosed and overlooked, undertreated. CPAP therapy improves blood pressure to some extent only when you scrupulously read the evidence-based medicine. So this is because heterogeneity of OSA is overlooked and the difference in treatment adherence is much problem. This is from the famous Journal of American Circulation. So obstructive sleep apnea, it's a highly prevalent disorder. You know the pathophysiology. Over past two decades, there has been a robust body of evidence linking the OSA and cardiometabolic diseases. Treatment of OSA with continuous positive airway pressure reduces blood pressure in individuals with hypertension, but beneficial effects on glycemic outcome is not convincing. Inconsistent cardiometabolic response to OSA treatment can be partly explained, as I told you, on the heterogeneity of OSA and variability of CPAP adherence. So in this talk, we summarize the relation between these two with the particular focus on obesity, hypertension, diabetes, and dyslipidemia. So the hypertension, OSA-induced sympathetic surge causes the sustained elevation of blood pressure. Intermittent hypoxia disrupts the insulin signaling and glucose metabolism. OSA drives central obesity, dyslipidemia, insulin resistance. In heart failure, mechanical stress from obstruction damages myocardium over time. Atrial fibrillation is due to arterial remodeling and electrophysiological changes. Stroke also, because of the hypoxia-driven endothelial dysfunction, raises this condition. So when you see the connection dot, intermittent hypoxia is the triggering factor, and you will see the oxidative stress enormously because of the intermittent hypoxia and arousal mechanism. Increased reactive oxygen species are emanated due to cell and which leads to cellular damage. Endothelial dysfunction also creates impaired vasodilation and vascular dysfunction. Insulin resistance because of impaired glucose uptake and increased insulin resistance. Sympathetic nervous system overdrive, that is because of the reactive hypoxemia, etc., which leads to the following condition: atherosclerosis, myocardial infarction, and arrhythmia in the cardiovascular sector. When you come down, hypertension also is consequence, obesity, type 2 diabetes, dyslipidemia. So OSA and cardiovascular metabolic diseases share a bidirectional relationship. Each condition can trigger worsen, be worsened by the either, creating a vicious circle. So when you see the hypertension, you will have OSA of 50%, 50 to 75%. So when you see the cardiovascular, it is 25-30% suffer from OSA. When you see the dysregulation in diabetes, you will see more than 65%. So microvascular complication also high in OSA. So when you see the cardiovascular complications of OSA, the mechanism will be, as I told you, OSA pathophysiology leading on to hypoxemia, reoxygenation, autonomic dysfunction, arousal and sleep disruption, intrathoracic pressure changes, and hypercapnia. When you see the mechanism, inflammation, atherosclerosis, endothelial dysfunction, hypercoagulability, metabolic dysregulation, hemodynamic changes, leptatory enlargement, sympathetic activation, collectively creating hypertension, atrial fibrillation, heart failure, coronary disease, stroke, pulmonary hypertension, metabolic syndrome, diabetes, and leading to mortality. So OSA triggers a cascade of pathophysiological changes that drive disease mechanism leading on to cardiovascular diseases and adverse outcomes. So OSA prevalence, when you see the Indian population, there are about 104 million people suffers from OSA. Up to 79% evaluated OSA patient have metabolic syndrome. When OSA patient has metabolic syndrome, this is known as syndrome Z, which is overlooked, underdiagnosed. So OSA MET co-occurrence dramatically amplifies the cardiovascular event. Women with OSA often face disproportionate underdiagnosis. So when you see the OSA culminating into metabolic syndrome, intermittent hypoxia one hand, another sleep fragmentation other hand, leading on to accumulation of fat deposition, which leads to sympathetic nervous activity increased, ROS activity increased, leads to hypertension, vascular dysfunction, cardiac remodeling. On the other hand, it creates emanation of cytokines, chemokines like interleukin 6, tumor necrosis factor alpha, high sensitivity CRP, C-reactive protein, leading to chronic inflammation, insulin resistance, endothelial dysfunction. On the other hand, when you come to the adipose tissue inflammation, you will create pro-inflammatory lipokines. So there are a lot of emanation of pre-fatty acids, accumulation of pre-fatty acids in the liver creates the insulin resistance, other decreased insulin sensitivity, leads to ectopic fat deposition, insulin resistance, and metabolic dysfunction. On the other hand, in the liver, there is a decreased glucose uptake, decreased insulin secretion, decreased insulin sensitivity, rather lipogenesis is promoted, which leads to hyperglycemia, dyslipidemia, and fatty liver. So, culminating all this, OSA creating a picture of metabolic syndrome, abdominal obesity, hypertension, dyslipidemia, insulin resistance, and type 2 diabetes or pre-diabetes. This is the criteria of adult treatment panel, National Cholesterol Eradication Program, criteria 3. So, now, finally, when you see OSA, along with metabolic syndrome, obesity is the number one. Then arterial hypertension, insulin resistance, reactive oxygen species, dyslipidemia. OSA contributes to obesity, hypertension, insulin resistance, oxidative stress, dyslipidemia. They are the key component of metabolic syndrome. So when you see the pathophysiology, same thing is happening. When on the other hand, in the hypertension sector, which we will be seeing, alluding in the next slide. So when you see the vascular damage because of sympathetic overactivity or reactive oxygen species and insulin resistance, elsewhere you will see the AWAC on the vascular damage. So this is a cyclic hypoxemia and reoxygenation, sleep disruption, negative intrathoracic pressure swinging, creating vascular damage in the form of endothelial dysfunction. When you see the flow-mediated dilatation, it is reduced. What is vasodilatory will become vasoconstrictory. What is not leaky will become leaky. What is not sticky will become sticky, favoring the emanation of atherosclerosis. So that's one side. Another side, there is a stiffness of arterial wall, which will be evidenced by increased flow pulse wave velocity. Another side, when you see this, there is a aortic dilatation, aortic dissection, aortic aneurysm. So OSA leads to cyclic hypoxemia, sleep fragmentation, negative intrathoracic pressure, which causes vascular damage, which was alluded. So when you see the type 2 diabetes, there are 72% patients with type 2 diabetes suffer from obstructive sleep apnea. There are certain cases which are overlooked. They are hidden, occult. So 86 of obese diabetic have OSA, which are occult and hidden. So OSA may have causal role in development of diabetes. OSA associated with insulin resistance. As I told you, obese patients with sleep apnea are more insulin resistant. 30% of patients presenting with sleep clinic have impaired glucose tolerance or diabetes, of which 40% are underdiagnosed. So mechanism leading to cycling, same thing, sleep deficiency or rather sleep disturbances, intermittent hypoxia, sleep fragmentation leads to sympathetic overactivity, catecholamine more release, disturbed fatty acid metabolism, ectopic fat deposition, oxidative stress, mitochondrial dysfunction because of emanation of reactive oxygen species mitochondrial level, HPA, hypothalamus pituitary axis activation, cortisol release, inflammation, endothelial dysfunction, all compounding produce insulin resistance and beta cell dysfunction and glucose tolerance, finally leading to pre-diabetes or type 2 diabetes. So the same pathological changes was leading to insulin resistance is the same picture. So OSA DM is a bidirectional relationship. Insulin resistance, hormonal dysfunction, inflammation, increases CV risk, all sitting together to produce all sort of AVAC. So OSA, obesity, metabolic syndrome, diabetes will produce organ damage finally, whether it is micro or macro. So now connecting the dots of obesity with OSA with gut microbiota. Obstructive sleep apnea produces gut dysbiosis at the gut luminal level, whereas when the common salt is absent, like lactobacillus or bifidobacterium or roseberia or persundis fragmentation, all these good bacteria, roseberia intestinalis, if they are absent, the pathogens will produce what we call it as LPS. The altered composition will produce lipopolysaccharide, which is an endotoxin, which will produce leaky gut syndrome. The leaky gut syndrome, when the endotoxin enters into circulation, it will produce metabolic endotoxemia. Metabolic endotoxemia will produce lot of emanation of cytokines and chemokines, which is a precursor for inflammation. The emanation of IL-6, tumor necrospector alpha and other chemokines produces insulin resistance. Insulin resistance will sit, there's emanation of increased blood pressure, glycemic dysregulation and fat deposition. So hypertension, diabetes, obesity. So there is a BMN mutation. You see, despite weight excess being an important pathogenic contributor of OSA, all OSA people are not obese. There are in Indian subsect, especially Indian subcontinent, you will witness lean obese, that is abdominal obesity, who has the OSA counterpart. So when you see the bariatric weight reduction through bariatric surgery or incretin agonist helps to reduce weight excess and respiratory events in OSA patient. However, there is a great variability of treatment response. So OSA after weight loss treatment rarely completely resolved. So there is a defect in the resolution of OSA due to weight reduction. So clinical implication is alternative and adjunctive therapy beyond weight loss alone must be considered for comprehensive OSA management, particularly in those with residual disease. So when you see the sleep breathing and cardiac arrhythmias in adults, arrhythmias also is produced. What is the reason for this? The inflammation that is occurring due to emanation of all sort of sympathetic activation or reoxygenation or arousal program, whatever they think. Inflammation is the number one. Number two, autonomic imbalance. Number three, myocardial fibrosis. All sit together in the cardiac circle, produce cardiac arrhythmia. Atrial fibrillation, ventricular ectopy, bradyarrhythmias. So OSA will intrathoracic pressure swinging, autonomic imbalance, decreased oxygen, that's hypoxia, inflammation, atrial remodeling, hypertension and heart failure all sit together to form atrial fibrillation. So whenever you have atrial fibrillation, it is always you have to look for the hidden OSA. So OSA and coronary artery disease, intermittent hypoxia, sympathetic activation, intrathoracic pressure swinging, all creating a lot of AVAC on the coronary sector. So arousal, sleep disruption, sympathetic overactivation, increased negative intrathoracic pressure, intermittent hypoxemia, all will stick together to produce all sort of constellation of metabolic syndrome like hypertension, thrombosis, dyslipidemia, insulin resistance, myocardial ischemia, endothelial dysfunction, all will produce coronary artery disease. So there is a enormous of evidence linking the OSA with heart failure. Heart failure, sleep disordered breathing are two common conditions that frequently overlap, studied extensively over the past few decades. OSA may result in myocardial damage due to intermittent hypoxia, sympathetic activity, transmural pressure changes, low-grade vascular inflammation, and oxidative stress. You know, the central sleep apnea, high-stroke breathing occurs in the cardiac failure. Pharyngeal collapse may result in part of the fluid accumulation when the patient resumes daytime fluid retention and overnight rostral fluid shift to the cranial part. So the sleep disturbed breathing and heart failure associated with worse prognosis, including higher mortality. So this is the diagram which shows there is a arousal phenomena and airway collapse, fluctuating thoracic pressure, all leading to the heart failure sector. So treatment of OSA and cardiometabolic disease. You know all this CPAP, oral appliance therapy, surgical intervention, weight loss, position, everything you are discussing from the morning. So these are all the gold standard, this CPAP, but the mandibular advanced device, airway corrective or targeting on the stimulation of hypoglossal nerve, everything you have discussed. But one should know the gold standard of CPAP is important in mitigating the symptoms of OSA as well as the accompaniment. Treatment of the accompanying disorder like hypertension, for example, valsartan like ARB is better utilized. The advanced emanation of the ARBs and SGLT2 inhibitors and the latest the GLP-1 receptor agonist, all helpful for mitigating the hypertension and diabetes, etc. So you know all the things which I do not want to dwell here. Modafinil, these are all the things which will be mitigating the daytime arousal. Excessive daytime sleepiness will be mitigated, and other things like lifestyle modification, like weight reduction, and all things. There are so many things. But one thing you should understand: that tripartite is the number one molecule added to the physician armamentarium in mitigating the evil effects of the OSA and the metabolic sector because of the successful trial of SURMOUNT 1 and 2. So SURMOUNT 1 and SURMOUNT 2 helps for the inclusion of this molecule in FDA, which has come to Indian scenario also. So combination therapy with the CPAP and tripartite is helpful to mitigating the cardiometabolic thing. So managing OSA in this sector, especially metabolic syndrome or syndrome Z, is posing lot of challenges. So we have to improve screening, improve diagnosis, improve risk stratification, improve prevention, improve treatment adherence. So the objective will be increased medical awareness. You should create, as Dr. Shankar Subramaniam, I will be telling, it's not an exaggeration, he is the one who spreads knowledge about OSA, which is an important cardiometabolic, it's a accompaniment of cardiometabolic disorder. Everywhere it is there. But only thing, prudent screening, prudent creating awareness is helpful for the public to cater the healthcare delivery in a nice manner. So ameliorate OSA detection in patient and diabetes, especially those with CVD and heart failure. Identify patient with high CV risk, identify patient with high risk of incident diabetes, prevent CV complication, prevent diabetes, reduce treatment withdrawal, increase in night time with CPAP. CPAP also should be prudently used. Awareness should be created. These are the tools which I do not want to do because of want of time. So when is the referral? Mild symptom, borderline screening, reasonable glycemic BP control, no major organ complication, initiate management before sleep testing, patient education, lifestyle, behavioral measures, primary referral, sleep physician, pulmonologist. ENT suspected anatomical obstruction severe, snoring with nasal, upper airway issues, cardiology, nephrology, parallel All these are referral should be given. The OSA tackling with the cardiometabolic syndrome is a team effort. So high-risk patient, early referral, poor glycemic control despite escalation, resistant nocturnal hypertension, atherosclerotic cardiovascular disease, heart failure, CKD, excessive daytime sleepiness, significant nocturnal desaturation, high-risk occupation, drivers, machinery operators, high-risk occupation like that. Urgent referral to sleep medicine specialist and concurrent cardiology review also appropriate. So in conclusion, OSA is associated with various chronic diseases like multiple body system, including cardiovascular, endocrine, genitourinary, nervous system. But the association of metabolic syndrome is very, very important because it is undermined. Therefore, comprehensive assessment of the cardiovascular risk associated with OSA conducted through screening method, targeted intervention, drug surgery, CPAPs, lifestyle modification is a primary objective of long-term intervention in OSAs is not only to correct sleep structure, but also reduce the incidence of hypoxemia, but also alleviate the cardiovascular system burden, minimize the risk of CVD, and enhance the patient quality of life. So, protect organs, improve sleep, reduce risk, enhance quality of life. I am very thankful to the ENT surgeons who embark on the surgical correction. I have referred so many cases to my dear friend Shankar. We have seen the good result. So it's a team effort. Thank you very much.
Sir, good evening, sir. Very elaborative presentation, sir. In case of a morbidly obese patient, sir, with OSA, what would be the gold standard, sir? What would be gold standard treatment method? CPAP or tracheostomy, sir? A morbidly obese patient with OSA.
Morbid obesity we classify into stages,
Yes.
but still I'll tell you, nothing like nowadays good bariatric surgeons are available, but now added with that there's a good agent like GLP-1 receptor agonist, semaglutide, liraglutide, and latest tirzepatide, both dual agonist. But still, nothing is substituted by like lifestyle modification. When a person takes good food, rich, enhanced with the fiber, that is a probiotic which we are seeing in our center. We have seen people are reducing weight at least 1 kg per month. We have to activate the gut microbiota to enhance the endogenous GLP from the gut, to act on the liver, to reduce the fat deposition, to augment the insulin secretion in pancreas. The twin cycle theory of Roy Taylor should work. So automatically the fat accumulation decrease, your glycemic control also will be, and also hypertension control will be there. So morbid obesity, it's a team effort. Surgery, bariatric surgery, and a good physician who knows the knowledge about receptor one agonist, GLP, and ENT surgeon. Because thickness, fat deposition on the glossal, upper neck, if it is removed by you, patient will definitely alleviate the symptoms of OSA.
Okay, thank you, sir.
Thank you, doctor.